Hi, I'm Bill Cushman, and I'm here with Dr. Matt Luther and Dr. Paul Muntner, and we're going to summarize briefly a session that we did at the American Heart Association hypertension meeting. The name of the session is "What Level of Evidence is Needed to Change Clinical Practice, Chlorthalidone versus Hydrochlorothiazide?" And this has been a very hotly debated question for many years. And so we're going to try to summarize the evidence and perspective in various aspects of this controversy. And the first presentation was given by Dr. Matt Luther from Vanderbilt. And so I'm going to let him summarize his part of the session.
So I'm Matt Luther, a nephrologist and hypertension specialist at Vanderbilt, where I direct the Hypertension Center. I'll provide a background of the physiology and pharmacology of thiazide diuretics, focusing on chlorthalidone and hydrochlorothiazide. My summary is that thiazides reduce blood pressure, and they both have proven cardiovascular benefits, but they also have known significant electrolyte and metabolic adverse effects. There is a major difference between the two drugs in that chlorthalidone is more potent on a milligram per milligram basis, has a longer half-life, and may reduce blood pressure more effectively than hydrochlorothiazide at the most commonly prescribed dosage. Additionally, chlorthalidone may provide superior cardiovascular prevention compared to hydrochlorothiazide in some analyses, and Dr. Cushman, Dr. Muntner will expound on some of the further evidence on that.
Thank you, Dr. Luther. So next, we're going to have Dr. Paul Muntner, who is going to discuss the presentation he made concerning secondary analyses of big data. Paul?
Thank you, Dr. Cushman. I'm Paul Muntner. I'm an epidemiologist at the University of Alabama at Birmingham. In my presentation, I reviewed some of the big data from observational studies on hydrochlorothiazide versus chlorthalidone. Over the past 20 years, very large data sets have become available for secondary analyses, as well as statistical tools that have allowed us to do research using these data sets, including comparative effectiveness research, such as the comparison between chlorthalidone and hydrochlorothiazide. In the studies I presented, I showed data from 3 different studies that compared head-to-head chlorthalidone versus hydrochlorothiazide. And the 2 large studies, one study from Canada that included about 30,000 people, chlorthalidone was not associated with a lower risk for cardiovascular outcomes compared to hydrochlorothiazide. Additionally, in a US-based study of almost 700,000 individuals, chlorthalidone also wasn't associated with a lower risk of outcomes compared to hydrochlorothiazide. However, it was associated with an increased risk for some adverse events. However, it's notable that the risk for adverse events was low in both of the treatment arms. When interpreting these data, we have to be very careful. These are observational studies. They weren't designed for a head-to-head comparison. So there is risk for residual confounding, and there is risk that there could be some bias in the conclusions of the studies. For this reason, I think that a randomized trial is going to be needed to answer this question definitively.
Thank you, Dr. Muntner. I'm Bill Cushman. I'm a professor and medical director in the Department of Preventive Medicine at the University of Tennessee Health Science Center. And I'm going to discuss a little bit about clinical trials comparing hydrochlorothiazide and chlorthalidone. Up until recently, there were many trials that used either of the drugs in outcome studies. Many of them were successful, but they never compared the two head-to-head in a randomized controlled trial. In the 1970s, the multiple risk factor intervention trial sponsored by National Heart, Lung, and Blood Institute allowed investigators to use either drug. And it turned out that whether it happened by chance or not, the chlorthalidone looked much better than the hydrochlorothiazide. And we discussed that in several of our presentations. And so from that time on, the National Heart, Lung, and Blood Institute major hypertension trials used chlorthalidone as the primary diuretic, in part because we knew what the dose was. And we know that those trials actually showed considerable success in lowering cardiovascular events with chlorthalidone as the primary diuretic agent. And then one major trial compared chlorthalidone with an alpha blocker, an ACE inhibitor, or a calcium channel blocker, and the chlorthalidone was at least as good and even superior for some outcomes compared with the other drugs. And so there's not, however, been a head-to-head study comparing the two, even though hydrochlorothiazide was used in some of the early studies quite successfully. But there are some trials that suggest that it may not be nearly as effective. We don't know whether that's just a dose effect or whether it has to do with the pharmacology and perhaps other aspects that have been discussed. And so Karen Margolis led a trial that was a pilot trial that compared chlorthalidone with hydrochlorothiazide in a pragmatic study, but looking primarily at whether it was feasible to do the study. They certainly didn't intend in that study to have major cardiovascular outcomes. But it appeared to be fairly successful to compare the two, and there actually weren't very many differences in blood pressure, for example, between the two. But within the last several years, the VA has started a large pragmatic cooperative study comparing chlorthalidone with hydrochlorothiazide for major adverse cardiovascular event outcomes in 13,500 participants. And I've been able to be the co-chair of that study, and we have been quite successful and have 8,000 or 9,000 of the participants recruited to the study thus far. And it's being done in primary care in a pragmatic manner. And so hopefully within the next several years or sooner, we'll have a definitive answer as to, in fact, whether there is any important difference in cardiovascular outcomes between chlorthalidone and hydrochlorothiazide. And then whatever the answer is, then that will help us to know how to go forward in our care of our hypertension patients. So I want to thank Dr. Luther and Dr. Muntner for summarizing their session, their talks as well. And we want to thank you for participating in this discussion. Thank you very much.